this year. Whenever I look back on the recordings, I always think I talk too much. So I'm going to be really, really brief today and introduce our speaker, who is far more interesting than I am. But before I do that, just a couple of words of admin, I guess. The first is just a warning we give it before every webcast that this is being recorded. So if you don't wish to be identified, you won't be identified during the presentation, but if you ask a question, there might be a risk that your name comes up. If you don't wish to be identified on the recording, please do let us know and we'll edit you out. That's the first thing. The second thing is this is the largest ever number of registrations we've had for a webinar, so I'm really pleased about that. And that obviously reflects the caliber of the speaker and also the topic, which is fascinating and great interest to us. One of the consequences of that is that I can't see you all on one screen on the gallery view. So questions, when people have questions, let's have a little practice of this. The best way to ask questions when you've got lots and lots of people registered is if you to use the chat function. So if you wiggle your pointer on the screen, wiggle, 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 up comes a bunch of boxes at the bottom, and right in the middle is chat. If you click on chat, up comes something on the right-hand side of your screen. And at the bottom, you can type in a message there. That's the best way to type in a question. Thank you, Paul Jackson. That is exactly what I mean. So you type in your question there, you send it, press return, and then I can see it. That way we can have questions coming in, join the talk, and I'll assimilate them and present them to Sue at the end of the presentation. So we'll keep all the questions until the end of the presentation, but please do use the chat function so that we can get the questions coming in as the presentation's going on. Hopefully that's all clear. The next thing, very quickly, we've got an awful lot of non-members who are joining us for the presentation tonight. Now, obviously it's open to non-members. That's perfectly acceptable and legitimate and all the rest of it. But we do need a few shekels to keep the Red Line group going. Our treasurer will be delighted that I'm telling you this. If you enjoy tonight and if you'd like to learn more about the Red Line group and indeed the support that we provide to Pouchitis throughout the country and beyond, then please do log on to the website, take a look at what we're up to. And if you feel so inclined, then join up. It'd be a delight to have you join up. And it's nice to have you as members. I think that's it for me. Having said I'd shut up, I've gone on a bit. So let me introduce tonight's speaker. I'm absolutely delighted to introduce Professor Sue Clark. Sue, apart from lots of other fantastic things, is our president. And I have to say, on behalf of the trustees, we're absolutely delighted to have your patronage, Sue. It's really great to have such a figurehead in the pouch world as our president, so thank you for that. Sue is also consultant colorectal surgeon at St Mark's Hospital, Centre of Excellence for colorectal surgery, including pouches operations, as many of you know, and has a significant academic involvement. She's a professor of practice of colorectal surgery at Imperial College, London. We're delighted to have you along, a world expert in pouch problems, which is pertinent for all of us pouchies. Over to you, Sue.
Well, thank you very much. And I'm very honoured to be asked to give this talk. I'm just going to share my screen and get my presentation up. I was thinking about how to do this talk. I give a lot of talks about pouch dysfunction. In fact, I'm just telling David, I was up at 3 o'clock this morning watching myself give a pre-recorded talk about pouch excision to an international meeting coming from New Zealand, and I then took part in the panel discussion. I feel very much that, you are the important people in all of this. You're the customer, you're the people with the pouch or thinking about a pouch or whatever. And I think sometimes we patronize our patients. I am going to show you exactly the same presentation that I give to doctors I'm using exactly the same slides as I used for one last year. Obviously, I modify them a little bit according to what the title is and what exactly I'm being asked. I don't think there's too much that's technical on there. I don't think there's too much that's gruesome other than potentially one slide. And I will try and explain things, but I have to explain things to doctors and surgeons when I'm talking about this anyway, because I think one of the things that people perhaps don't appreciate is how unusual pouches are. You know, I think about 6,000 pouches have been done in the UK, probably. I don't know whether you know of a different number, but it's something in that ballpark. Now, there are 600 consultant colorectal surgeons in the UK. That means there are 10 pouch patients per colorectal surgeon. And if we think that perhaps at 10 years, 1 in 10 pouches will fail, and perhaps half of the pouch patients will have some degree of problem, that means that each colorectal surgeon will only ever see about 5 patients with pouch dysfunction and 1 with pouch failure. And that's colorectal surgeons, you know, and patients come to clinic and say, well, why doesn't my GP know what to do? Well, your GP's probably never even heard of a pouch. General surgeons probably may not know anything about them. And actually, most colorectal surgeons have very limited experience. And the experience that I've got, I have to say, I've gained rather painfully. And I can see on the list of participants some familiar names who I think have been on this journey with me. You know, I took over from John Nichols in 2006 at St Mark's. I'd been his trainee, which was a great relief because it meant that I did know something about pouches. But suddenly I had to look after all of these people at St Mark's and then all the referrals with pouch problems with nobody to help me, because there was nobody who knew any more about it. And I had to, with help from all my colleagues, from the gastroenterologists and various other people at St Mark's, work it out. And of course, at St Mark's, we have so many pouch patients and so many patients referred that I've actually seen enough patients, I think, to manage to learn something. At least I hope I have. And I try and impart that because it's completely hopeless to expect every colorectal surgeon to work this out for themselves. And there are a couple of things about pouch dysfunction and pouch surgery, and I'm just going to put these in at the beginning before I forget to say them. I have bees in my bonnet that I sort of go on about at colorectal meetings. The first is that the pouch is not a medical operation in the sense that forming a pouch is not treating anything. Removing the colon and rectum is treating ulcerative colitis or FAP or whatever other condition the person is having the surgery for. That is the bit that's treating them. Making the pouch is an addition to that to avoid a long-term ileostomy. But it in itself is not medically helpful. That's perhaps the wrong word. But it is not part of the treatment. It's an addition to the treatment. And it's a bit like a plastic surgery reconstruction. It's a bit like a woman who perhaps has an extensive mastectomy for a breast cancer. That's the bit that does the treatment, but then has a major plastic surgery procedure afterwards. Now, those sorts of big plastic surgery procedures are very, very carefully governed in this country and in most European countries in terms of credentialing who's allowed to do them, and in terms of making sure that the patients understand the risks and benefits in very great detail. We have nothing like that formally for pouches, and I think we should, because I think the stakes are actually higher than they are for some of the plastic surgical breast reconstruction operations, in terms of what can go wrong if it goes wrong, and the risks that maybe people may be taking. And so I really think that it needs to be regulated in terms of credentialing of the professionals and in the way that patients are managed in the same way. And then the other thing about pouches is, I said, there are about 6,000 in the country, roughly. The other main thing I do at St Mark's is a thing called polyposis, which is a rare set of inherited bowel cancer predisposition conditions, and some people on the call may have FAP, because we do pouches for people with FAP sometimes. There are about 6,000 people in the country with FAP. FAP is a rare disease, and NHS England is now saying that rare diseases should only be looked after in specialist centres by experts who have enough volume experience and enough patients to be able to provide proper multidisciplinary care. So I think pouches, having a pouch, is a rare disease. Basically, it's a rare thing, and people with that rare thing need to be looked after in specialist centres, in my view. Anyway, that's enough of me banging on about that. So we are guilty, I think, as surgeons, of glossing over the realities of what can happen with pouches. You know, we say to patients who are, for example, having an urgent subtotal colectomy, don't worry, your stoma is only going to be temporary, you can have a pouch, it's all going to be great. We write things in papers like pouch is the gold standard operation for ulcerative colitis. Well, I don't even know what that means. What does that mean? It's an option, and it's the only option. What, it's actually probably not the only option, but it's probably the best option for avoiding a permanent ileostomy. But I don't really know what gold, it makes it sound like it's really, you know, absolutely rocks, you know, guaranteed rock solid outcomes, which is complete nonsense. And I think we're rather guilty of showing patients that their life will be like this. You know, whether you could mountaineer, ride a bike beforehand, once you've got a pouch, you'll be doing all these things and it'll all be wonderful. And we're not very good about the reality. And this is my gruesome slide. So if you're feeling a bit faint, don't, oh no, the gruesome slide is coming. The outcomes, this is what I tell patients who are thinking about having a pouch to expect. So going to the toilet about 5 times a day or once at night. About 1 in 5 people will have seepage at night and need to wear pads, and that will get worse as people get older. About 50% have minor treatable problems, but things that are pretty easily overcome. But there is a minority, and a very real minority, 10 to 15 to 20% of patients who have really difficult problems, some of which we can't solve. And a proportion of those, probably about 10% at 10 years, have got pouch failure, which means the pouch has been taken out or they've gone back to a permanent ileostomy. And in my experience, about 20% of patients struggle with pretty poor function. And one of the problems we have is actually not being able to predict accurately who is going to do well and who is going to do less well. Because obviously we knew that, we would tell people, and we wouldn't do the ones that don't do well. So that's what we tell people to expect. But of course, that's an average. And we all know people who go to the toilet twice a day and never get up at night. I know patients who go far more often, and there is nothing wrong with their pouch. So these averages are just averages, and some people do better and some people do worse. But these are the problems that we're not good at telling people about. And aside from the model in that wearing that pad, these are all patients I've looked after with Pouchitis. That's an endoscopic view of Pouchitis on the left there, with some ulcers and a sore and unhappy looking pouch. There is a wound with a fistula, small bowel fistula coming out of it following pouch surgery. There's a patient with very high frequency and what I call the blowtorch bottom, that looks as if somebody's taken a blowtorch to their bottom. And I see too many people like this. I don't know how people can live like this. It's just awful. And fistulas associated with pouches, that's controlled with aceton. That's what that blue string is. And this is a Medina catheter, which I think some of you may use and some people use to empty their pouch, which is, you know, it's not ideal by any means. And I think sometimes we don't warn people they may need to use something like that. The other problem is beginning to arise is as people get older, they're getting more and more problems with their pouches. You know, we've got patients who need to use a Medina catheter and it's fine, but when they get very frail, if they have, for example, a stroke, they can't insert the Medina catheter anymore. If they have arthritis in their hands, or if they have an acute problem and get admitted to hospital, you know, fall over and fracture their hip, for example, you know, they're lucky if they even get the chance to take their Medina catheter with them. They'll end up in a hospital ward, in a hospital with doctors and nurses who have no idea what they're talking about, don't have the equipment. They can't empty their pouch, very difficult. The other thing that seems to happen as people get older, obviously their muscles get weaker, so continence is less good. And also when you empty a pouch, when you empty a normal rectum, the actual bowel squeezes. That's what it's designed to do. And you can actually just sit there and relax and it'll all happen. Pouches are different. The pouch configuration, the pouch itself doesn't contract. What happens is you brace your abdominal muscles and increase the pressure and relax your pelvic floor. And that's how you empty the pouch. And as you get older, the tummy wall muscles become less strong and that's more difficult. So people have problems with continence, but also problems with emptying. And we are beginning to develop a really quite big cohort of people in their 70s and 80s now who have pouches who are going to get problems. And I think that's something we haven't really thought about. Now, you can write a long textbook list of all the things that can go wrong with pouches. I'm not going to grind through all of this. And I don't think it's really very helpful other than sometimes as a checklist for a doctor, but fundamentally pouches can get inflamed because of infection outside them, irritating them, because of pouchitis, because of infections. You can get gastroenteritis in your pouch. You can get, the pouch itself can be fine, but you can get infection of the anus and what we call perianal sepsis, that's abscesses around the anus and fistulas in people with pouches, which can cause a problem even if there's nothing wrong with the pouch itself. We see quite a lot of mechanical problems, so narrowings, too much rectum left behind so that there's just a long way for the pouch to have to empty through, narrowing of the inlet, problems with the anal sphincter strength. Sometimes pouches are made too small, sometimes pouches are made too big. And I've seen twists as well, and U-bends. What I mean by U-bend, let's go back to that. That's a JPouch, which you're all familiar with. Basically, the two limbs of the J are actually joined together so that the poo can go straight across between the two. It's all one bag, as it were. But I've seen a few of these done with a stapler, where the stapler has joined the two bits together, but not actually, it's fixed them together, but not joined them. It's not cut the bowel between them. So instead of this thing being one big bag, it's actually a U-bend. And that doesn't tend to do terribly well either. It's possible to get precancerous change or cancer either in the rectal cuff below the pouch or in the pouch itself. That's very, very rare, but it can happen and obviously present with problems. And some people, we actually can't find anything actually wrong, but clearly the pouch is very irritable. And we call that irritable pouch syndrome, a bit like irritable bowel. So that's a sort of checklist of the things that can go wrong. And this is one of the biggest series of pouches. This is from the Cleveland Clinic. So I think it's about 6,000 or so pouches done at the Cleveland Clinic. They've probably got some of the best outcomes around. And you can see there that there is a pouch failure rate of 5%, which is extremely low and very, very impressive. But they too have all of these complications that occur early after pouch formation. So leaks from the joins, infection, bleeding, wound infection, those sorts of things. And then later complications, ongoing infection, fistulas, strictures, pouchitis, all of those things, also in that series. But of course, patients don't come along and say, you know, actually my pouch is a U-bend, or I've got primary idiopathic pouchitis, which is the longhand for pouchitis. Patients come saying, I go to the toilet too often. Now, why might that be? Well, it could be because the pouch is inflamed and irritable. So when it fills with poo, it doesn't like it and needs to empty quickly. It might be that they're not emptying completely, so they have to go very often because they're not ever really emptying the pouch. Or it might be that there's something wrong with the bowel upstream. I've actually diagnosed more people with celiac disease than with Crohn's disease who have pouch dysfunction. So just because you have a pouch doesn't mean you can't suddenly have something else wrong with the bowel upstream, and we always need to bear that in mind. And you know, that could be something like celiac or Crohn's, or a number of other things. The next commonest symptom that people complain of is pain around the back passage, and that can be because they're leaking, and pouch content is very alkaline, very caustic, very irritable. So if you just get a little trace of it, either because you're leaking a bit or because you're going very often, that causes nasty ulceration and irritation of the anal skin. But of course, if you have an abscess of the anus, that is, or a fistula, that can also cause anal pain. So it's important to examine and see what's going on. People come and say that they're leaking, and that's usually because the anal sphincter muscles are not strong enough to contain the liquid content of the pouch. But it also sometimes because they're not emptying properly. If you can empty the pouch fully, then the sphincter has less of a job to do. Whereas if the pouch is always partly full, then the sphincter has to be working the whole time. And finally, people come and say they have difficulty emptying, and which might be due to an actual physical stricture or narrowing where the pouch has been joined to the anus, or it might be that they just can't empty. There's no actual blockage. They just can't empty. And people often say to me, well, why can't I empty my pouch? Well, I kind of turn it the other way around. And I think it's absolutely amazing that you can get a piece of bowel and turn it into a bag and join it onto the anus, and people can be aware that it's full and they can empty it and have control of it. I mean, that is amazing to me. And it's not surprising that sometimes that doesn't actually work. So I think that doctors tend to get very bogged down in wanting to explain everything, wanting everything to be better, wanting to understand, wanting everything to be neat. I don't think in this situation of pouch problems that you can do that. I think people often have, you know, I've shown you some of the symptoms. Many patients come with all of those symptoms in combination. And my approach to this is to try and be practical. I want to try and work out whether there is a problem that I or somebody else can fix. And if there is, fix it. And if there isn't, be really clear to the patient that there isn't anything we can do, and they either need to soldier on as they are, with obviously as much support with diet, barrier creams, all of the rest of those things as possible, but that I can't do any more, and they either need to carry on as they are, or it's fine to go back to an ileostomy if that's what they would like, with or without pouch excision. And I think it's very important that people know that while many may not want that or be at a point where they feel they need it, that people are aware that it's there as an option. And people need a lot of support. I think, you know, even a well-functioning pouch is not an easy thing to live with, let alone a problem pouch. And we're really fortunate. This is an old photo. I need a new photo of the more up-to-date pouch team at St Mark's. Zara is still with us, but Sam has got a new existence and seems to be turning into a surgeon. Lisa has moved on and is doing inflammatory bowel disease. So we've got Petya and Raleigh now. So I need a new photograph. But they are just fantastic because they can spend time helping explain to people in a way that the doctors actually are not very good at. We claim we don't have time, but it's actually because we're not really very good at spending time talking about diet and how to empty your pouch. And the thing that I say to people who are thinking about having a pouch is that, look, you know, if you're getting a car, you can go out and buy yourself a Toyota Yaris or a Ford Fiesta, and it's, you know, pretty cheap as cars go. You can take it to any garage and the bloke will be able to fix it up. You can go to Halfords and buy parts yourself. You can get a manual. It's a sort of universal thing, and it's reliable. Or you can have a magnificent machine like the one on the right, which is a thing of great engineering achievement. And when it's working is just magnificent and everybody will be jealous of you. But it needs proper mechanics and specialists to look after it. And it will conk out at the side of the road, and it will need the right garage to deal with it. And I think that's what we and our pouch nurses are. We're the guys with the oily rag who are trying to keep this wonderful vehicle on the road. And I sort of say to people, you need to decide what you want. If you want the risk, but also the joys of the thing on the right, then maybe a pouch is for you. But if actually what you want is something highly reliable and not risky, go for the thing on the left, which is an ileostomy. So what do our pouch nurses do? Well, I'm sure you're probably all aware that they've produced so many information leaflets that they've now turned it into a book. And it's about expectations. You know, people need to know what to expect. You know, I still come across people who've had their pouches done elsewhere who actually think that they'll go back to being how they were before they were even unwell, that they will be normal, whatever that is. So it's important for people to know what to expect in an honest way, to have some support, dietary advice, talk about fluids, electrolyte supplementation, and all of those, the balance of antidiarrheals, bulking agents, barriers, creams and wipes, catheters, how to irrigate, and access to support groups. Now, in terms of managing pouch dysfunction, bear in mind this is a presentation that I use for usually colorectal surgeons. I tell them to use an algorithm. That's a flow chart, because when you do that, you know when you've come to the end of it, you know that you haven't missed anything out. You can share with the patient what it is you're trying to do and where you're going through this pathway. And they too can see, if you get to the end of it without success, that you've got to the end of it. Because I think people often, including doctors, partly because they're not that familiar with this, always think there's one other test that we could do, or one other thing, or let's do it again, or let's go and talk to somebody else, that maybe I've missed something. I mean, it's obviously right to think that, but at the same time, actually that can make people spend an unnecessarily long length of time in a pretty miserable state when they don't need to. So an algorithm can be very helpful. There are certain very common pitfalls, and I'm going to show you what they are so that you can be aware of them too. And it's important that that the clinicians are aware of these pitfalls, because they're the same old things we see over and over again. And as I said right at the beginning, patients with pouch problems really need to see experienced clinicians who are used to dealing with these problems. And places that don't have that, you know, I often talk to doctors who say, oh, well, yes, but we don't see very many pouches. Fine. This country is not that big. There are places around the country like Leeds, Oxford, us, Plymouth. There are lots of very respectable pouch centres. Nobody really has to go that far. In my view, there is no excuse for saying, oh, well, I don't know what to do, and I've never not seen this very much, so, you know, sorry. You need to be, these doctors should be referring patients to somebody who does know what they're doing. My plan of investigation is very, again, I'm a simple soul. We surgeons are quite simple souls, really. I want to think about looking inside the pouch and the anus. So is there inflammation in there? What does it look like in there? So we do a flexible pouchoscopy to actually look at the lining and take biopsies. I often do that, that's examination under anaesthetic, because often people with pouch dysfunction have terribly sore bottoms and just can't tolerate a pouchoscopy awake. Sometimes until you examine them asleep, you don't know if there's a narrowing, and obviously if there's a narrowing, they actually can't do an endoscopy, a pouchoscopy in the endoscopy department. The patient needs to be put off to sleep for that to be widened up. So I often do that all in one go, put them off to sleep, examine them, dilate any narrowing, so that I can then do a pouchoscopy with them asleep, and it's much more comfortable. Pouchogram, that's putting X-ray dye into the pouch. I have to say, I do sometimes do it. it's not that helpful in most cases. There are certain scenarios where it's useful, but not many. So that's looking inside the pouch. Then we want to look at outside the pouch, the area in the pelvis around the pouch, to see if there's, for example, an abscess that is irritating the pouch, or if there's something like a lump, you know, a tumor or some other thing. I mean, sometimes women get fibroids in the womb that are pushing on the pouch, making the pouch smaller than it should be. You know, you need to look outside the pouch and see if the rest of the pelvis is okay. Then looking at the anal muscles, we can do physiology. So that's putting a little probe into the anus and getting people to squeeze and actually measuring the pressure, so you can actually see how strong the muscles are. And then we can put a little ultrasound probe in and actually scan the muscles and see if there are any, if there's been damage to the muscles either at childbirth or because of surgery. And then the defecating pouchogram is when we put X-ray dye into the pouch and then take a video X-ray as people poo to see whether they can empty their pouch. And again, that's sometimes useful. If I find it more useful really to convince, some patients are very unkeen on using a catheter. If you can actually show them that there's a lot of poo in the pouch that they can't get out, that helps them understand why they need that and encourages them to use it. I mentioned the rest of the bowel. Well, we want to make sure there's not something else wrong further up, so we do some kind of imaging, CT scan or an MRI of the small bowel to look above the pouch. Sometimes we use a video capsule if we think somebody might have Crohn's, to actually look for ulcers. I also do blood tests. I look for a celiac screen to check they don't have celiac disease, and thyroid function. You know, occasionally you can get very severe overactive thyroid that can give people diarrhea. Well, if you've got a pouch and you get that, then it can be quite dramatic. So we look at the rest of the patient as well. And a CCAT scan is just a thing to look for look at bile salts. I'm not going to go into that because I'm not actually sure how helpful that really is. Now, this is quite an old algorithm that was put together by Simon McLaughlin and published in 2008, but it's still quite useful. And we start off with examining the anus and the joint between the pouch and the anus. And if it's narrowed, then it needs to be dilated, usually with the patient asleep. Sometimes you can do it with them awake in clinic. I managed to do one on Monday actually in clinic with somebody awake, and they've tolerated it very well. And then we can give them dilators to keep that open. I'm sure some of you have used dilators. It's not very nice. I mean, it's just a sort of little metal rod that you put inside every few days. Some people need a Medina catheter, which both dilates and helps emptying. And sometimes we actually need to do surgery to open up strictures. I tend to only use dilators if people have a recurrent problem. If I dilate it once with them asleep and the problem doesn't come back, I wouldn't give them dilators because people don't, you know, nobody wants to use them. And I've come across all sorts of things. I've come across a man who was told he needed dilators and the hospital didn't give them to him, so he got them on eBay. I've come across people being given them in a brown paper bag in the hospital, other hospitals, not St Mark's, I hasten to add, and just sent away with no idea what you do with it. We've got an instruction sheet, and the pouch nurses will spend time showing people, making sure they know what to do, and then give them the instruction sheet as a reminder, and obviously contact details to get back to us to go through it again if there are problems. Same with the Medina catheter. There's no point in just posting somebody a Medina catheter, which again I have come across as a thing. People need to be shown how to use it, how far in to put it, what to do. And given something to remind them when they get home. And that's what we do. I've put that for doctors. I don't want to worry you about this. It's very, very rare. I have just in my career come across a couple of patients who had been fine for many, many, many years, and then suddenly out of the blue with no reason got what was labeled as a stricture, a narrowing at the joint, which was actually a cancer. And it's just something that I tell doctors to think about. If somebody has no problems for 20, 25 years and suddenly they develop a stricture, you've got to ask yourself why that is, because that's very odd. Most people who have strictures have problems with them right from the beginning. because it's to do with the scar tissue. And if it is not a problem, then suddenly is. That's a bit weird. If people are having trouble with leakage, you've got to make sure they're emptying completely, which might need a Medina catheter or an aqua flush. Biofeedback can be helpful. Occasionally, a sphincter repair operation can help. And these people, I don't like taking out pouches. If people have pouch failure, I like to make an ileostomy, get people well. And then many people don't need a pouch excision. Some do, because the pouch causes problems if it's not in circuit. But many people can live for a long time with a pouch not in circuit, just with an ileostomy above it. But I have learned that if the problem the person has is incontinence, they're usually incontinent of mucus after they've got an ileostomy formed. So I would recommend their pouches taken out at that first operation. This is a real regular chestnut. So when you examine the patient, you realize that the join is much further away from the anus than it needs to be. And that's what we call a retained rectal cuff. And that can be inflamed because that area still has ulcerative colitis or ulcerative proctitis, because it's still large bowel, and that needs treatment. And sometimes that can respond very well to things like azicol or prednisolone suppositories to get the inflammation to settle down. And that can really help the symptoms that people with cuffitis get. And that's a cuff. So what this is a view, that's a pouchoscopy, and that's what we call a retroflexed view. So the scope is actually turned looking back on itself. So it's coming in through the anus, and the endoscopist has bent the end over and is looking right back at the anus. And actually you can see there's a sort of two different kinds of tissue. Out on the outside, there's pale, healthy looking tissue. That's actually the pouch. And then there's a join, which is about 1 centimetre or so from where the scope is going out through the anus. And that area looks a little bit red, and there are little tiny ulcers there. That's a rectal cuff, and it's a little bit inflamed. That's a short rectal cuff. That's enough to cause symptoms, but you can imagine that, using suppositories on that, it's a bit like putting steroid ointment or an anti-inflammatory ointment onto eczema. It's a topical treatment that gets right to where it's needed and can really make a big difference. But what I do see quite often is this, and I'll walk you through this. This is not a cuff. This is basically the whole rectum, virtually the whole rectum left in place. So it's probably easier to see on the view on the right. I hope you can see my arrow. The pouch is this sort of horizontal capacious thing in the pelvis, and the join actually from the pouch to the rectum is somewhere about here, and then there's about 7 centimeters, so it's about half of the rectum is left, and then the anus. Now, and you can see the same thing. This is a pouchogram with X-ray dye put into the pouch. This is the pouch lying sort of horizontally with the blind end of the JPouch, and that's going to the small bowel. And then there's the join, and then there's half the rectum. Now, there are two problems with this. The first is that this rectum has still got ulcerative colitis and is inflamed, and it acts as the other problem is it acts as an outlet obstruction, because I said, you have to use a bit of oomph from your abdominal muscles to actually empty the pouch. Well, if you're trying to oomph and you're pressing against this resistance effectively of this great long bit of rectum, there's no way that you can empty this pouch satisfactorily, even if the rectum was healthy. But if it's inflamed as well, this is not going to work. And this is actually at surgery. So and we see this all too often, because this is inexperienced pouch surgeons who don't appreciate that you have to go all the way down to the pelvic floor, remove the whole rectum, and join the pouch just above the anus, leaving no more than 1 centimetre or so of cuff. So in this picture, the top area is actually the pouch. It's still got its blood supply, it's healthy. And then the lower part is the rectum that shouldn't have been left in place at the first operation. So we took that bit of rectum out. You can see I've detached it from the anus. And then I divided across, got rid of the rectum, and then put this pouch, joined the pouch where it should have been in the first place, right down low onto the anus. And I took these photographs because the surgeon who'd originally done this, when I wrote to them and told them what I'd found and what I was going to do, got very cross and said it was completely impossible that this is what I'd found. And was I saying they didn't know how to do pouch surgery? Well, I didn't say anything, but I thought that they might want to have some actual proof of what was left. So I took the photos. So once you've examined the patient, if there's no stricture, they can then have a pouchoscopy with biopsies, and we may find that the pouch is inflamed, or the small bowel above the pouch, the pre-pouch ileum, is inflamed, and we have an algorithm for treatment of pouchitis. We've talked about the retained rectal cuff, and we treat that as if it was ulcerative colitis. Strictures, we've sort of talked about dilate or potentially do surgery. If somebody's got a very small pouch, you might actually, that might be something that it's worth, that there's a good outcome if we actually do an operation and make a new pouch. And if they've got, if the defecating pouchogram shows that there is no blockage to defecation, but they can't defecate, it's what we call functional, and we need a Medina catheter, biofeedback, and so on. So pouchitis, so when people talk about pouchitis, what they mean, well, pouchitis just means inflammation of the pouch. Itis just means inflammation, okay? So tonsillitis is inflammation of your tonsils. Pouchitis is pretty meaningless. It just means an inflamed pouch. What people usually are talking about is what we call primary idiopathic pouchitis. And what that means is it's like ulcerative colitis of the pouch. It is an inflammation that we don't understand why it's there. It's only of the bowel. It's only of the pouch and a little bit of bowel above. And it is essentially a form of ulcerative colitis. Now, the problem is that is quite common, and we treat it. The first line treatment is antibiotics. We use ciprofloxacin. You really need to have a pouchoscopy to diagnose it properly. The problem is that everybody knows, one thing that any doctor who knows anything about pouches knows is that pouchitis is the commonest complication. So if anybody with a pouch has any problem at all, they get labeled as having pouchitis, even when they don't, or primary idiopathic pouchitis. So we tend to say, look, if somebody's got what sounds like primary idiopathic pouchitis, treat them, give them ciprofloxacin, because it's hard to get a pouchoscopy. Just give them 2 weeks of antibiotics. If it gets better, fantastic. If it doesn't, you then really need to make sure that you've got the right diagnosis. You know, are you actually missing something else? Are you missing an abscess outside the pouch that's making the pouch look inflamed? And actually that may respond to antibiotics and even steroids, and will come back when you withdraw those drugs. And those patients could be labeled as having recurrent or antibiotic dependent pouchitis when they haven't got primary idiopathic pouchitis at all. What they've got is an abscess next to the pouch that's making it inflamed. So you've got to make sure you're not missing that. You've got to make sure that you're not missing Crohn's disease that's affecting the bowel above the pouch as well, because actually that may respond very well to proper Crohn's treatment. You've got to make sure you're not missing infectious gastroenteritis. Sometimes people who can't empty their pouch looks inflamed just because it's never emptied properly. So if people don't respond, it's really important to go through these investigations and make sure that you're not missing something else, and not just slavishly keep saying that somebody has primary idiopathic pouchitis. This is an example of a patient with a pouch. This is an MRI scan. You can see this is the pouch. At the back of the pouch, it all looks very raggedy here and inflamed, because it is. And when you put a scope in here, it will look red and sore, particularly at the back. And you think, oh, pouchitis. Well, it is pouchitis. It is an inflamed pouch. But the reason it's like that is because behind here, this thing here, between the sacral bone and the pouch, that is an abscess cavity that is being caused by a small leak at the anastomosis. And this is irritating the pouch. And of course, if you give the patient antibiotics, it gets a bit better. If you stop the antibiotics, it comes back. So the next thing is that you know, they seem to have antibiotic dependent pouchitis, which is not what they got at all. we actually, I'm not going to bore you with this, but we actually looked at the patients referred to St Mark's with what was supposed to be difficult primary idiopathic pouchitis. There's a very select group. It's people sent from other hospitals where they were struggling to manage this so-called primary idiopathic pouchitis. When we actually MRI'd them, we found that 63% of the men, there were 68 patients, 63% were men. 38% of these people, so over a third, did not have primary idiopathic pouchitis at all. They actually had an abscess behind the pouch. So in summary, we need to support people who've got pouch dysfunction. We need to manage expectations both before people even have a pouch, but also once they've got a problem, manage expectations of how likely we are to be able to sort it out. Identify what their needs are. Sometimes we're not very good at actually listening to our patients about what actual aspect of their problem is impinging on that particular person's life, and trying to tease out, if they've got lots of problems, is there one that's the main thing they want sorting out, and trying to focus on that, because that's really important. All of this, the advice about diet, emix, antidiarrheals, all of that is very key. If there are narrowings, we need to dilate them up if we can. Give biofeedback or catheterization if there's problems emptying the pouch. If there's infection, identify and drain it. If there isn't and there's an inflamed pouch, treat it properly for primary idiopathic pouchitis or Crohn's. If there are fistulas and infection, control it. Redo pouch surgery has a place. I think it is much more successful if there's a mechanical problem with the pouch, like it's twisted or too small or it's a U-bend. If there's a problem with infection outside the pouch, putting a new pouch into an infected pelvis is a pretty unpromising thing to do, and probably is why there is such a high failure rate. Overall, there's about a 50% failure rate for redo pouch surgery, but that's probably less for the mechanical problems and more of a failure rate if there's infection. And I think we need to be a little bit more sensible as surgeons about when we try to redo a pouch, and also when to stop, because I think patients get swept up in this kind of merry-go-round of investigations, and every time somebody suggests another investigation, it sort of implies that there's some hope that there's something that you're going to be able to do. And actually, sometimes that needs to, we need to be honest and stop and say, look, we've looked for everything that we can fix. We haven't found anything. Are you in such a bad way that you would like an ileostomy? And not put people through unfounded hope, not give them straws to clutch at that are unrealistic, and to be honest. One of the problems, though, with failed pouches is that the permanent ileostomy is often not in a great position because there's scarring from previous surgery, and in particular previous stomas. And of course, people have lost bowel. They've lost at least 45 centimeters of bowel in the creation of the pouch they've had. So sometimes these are quite difficult high output stomas. When you're talking about having a pouch operation, people say, oh, well, I'll give it a go, and if it doesn't work out, I'll go back to an ileostomy. Well, it's not as simple as that, because the ileostomy that you have if you have a pouch defunction will never be as good as the ileostomy that you will have before a pouch is made, which involves the whole of the small bowel length and is usually on an unscarred abdomen. Pouch excision itself is a pretty major operation. In men, there's a 10 to 15% of problems with erections and ejaculation afterwards. Perineal sinus, when we take out a pouch, we also remove the anus. And you have to do that because otherwise you get infection in the pelvis, but sometimes it doesn't heal. I think that 40% rate is probably too high, probably more like 25% now, but it is a pain to have an unhealed opening in where the anus was. It's for some patients it doesn't cause much problem, others it does, and we end up having to do more surgery to get rid of it. So there's considerable ongoing morbidity. If somebody's got a problem with their pouch, it's a problem if they carry on, but it's also a problem if you give them an ileostomy and or remove their pouch. And while we know that nobody wants an ileostomy and we want to try very hard to avoid it, I think we need to be very honest that the pouch alternative is not a panacea. There are some people who have got fantastic functioning pouches, and that is brilliant. I worry about what will happen when they get older. And we've got to make sure that there's a group of surgeons trained to deal with that. But we also need to encourage people who do have an ileostomy that you can live a very normal life with it, and that there's nothing wrong with that. And that for many people, it may actually be, they may want the Ford Fiesta that's going to get them from A to B and be reliable. So that is the end of my presentation. I'm going to stop sharing my screen. And I hope that somebody's been looking at the questions on the chat, because it's very difficult to do that as you're going along. So questions, I'm open to questions.
Well, thank you very much indeed, Sue. That was absolutely fascinating and very different, I might say, from what we might call the usual presentations we see, and very very pragmatic, very realistic. So I've got 2 or 3 questions. We've only had 2 questions, or 1 question and 1 comment tabled. So first of all, before I pile in, ladies and gentlemen, you can type away on the chat function, wiggle your cursor on the screen, up come the buttons, right in the middle at the bottom is chat. Click on that and you can type in to everybody a question, and I'll represent it as best as I can. The other thing you can do, if you wiggle your cursor on the screen, go right to the right, there's a button called reactions. If you click on reactions, up comes a number of options. One is raise hand, and we'll see if the raise hand will work, although there are a lot of people on the call, so you're not all on one screen. I did mention it before. Anyway, let me start just while other people are formulating, because that was fascinating. That was absolutely fascinating. I see Davinder's got his hand up. There's a couple of things. First of all, you mentioned a few times there, Stu, the importance of experienced centres, both the surgeons being experienced and also having support staff, such as the tremendous pouch nurses who are able to help pouches when they have problems. The 2017 pouch survey, which I still think is the most sort of comprehensive follow-up of pouch outcomes, made a very important point that I'm sure you're aware of, which is that experienced centres get better outcomes than inexperienced centres. It also made the point that there was a huge number of inexperienced centres that did pouch operations, maybe 1 operation in 5 years. So my own theory there is that it was a fashionable operation at one stage for colorectal surgeons to have a go at, and some of them had a go at it. And as your example showed, some of them didn't do that great a job at it. If you speak to one of your colleagues, Janindra Warisavitani, he actually puts a number of pouch operations, a number that define an appropriate experienced surgeon, which I won't share. But anyway, one of the key challenges for us patients, pouchies, is how do we know if we get problems where to go? How do we know where the experienced centres are? Put your hands in your head, hands.
No,
I mean, you know.
Well, you know, you should be asking. Well, that is quite difficult. So historically, you know, you're right. What happened was John Nichols and co. They invented the pouch. A whole generation of trainees went through and were taught how to do it, and solemnly continued, even when they worked at hospitals, you know, all over the country, and would do, you know, 1 a year. Mm-hmm. And those guys, actually, some of them were probably very good and sensible and had John Nichols's phone number and managed those patients okay. They then retired, and those patients are marooned, being looked after by people who have got no idea.
Yeah.
There seem to be some surgeons who are younger with less experience as trainees who seem to think it's okay to do a few pouches. Now, I think those kind of surgeons are going, but there still are. You know, I'm just horrified, and I, you know, this is a professional problem, and it's a minority, but there are some people out there, and I don't understand their mentality. It's that I'm as good as anybody else. I can do it. Not about being as good as anybody else. It's about, do you have the infrastructure? Do you have the telephone hotline for the nurses? Do you have a gastroenterologist who knows how to teach pouchitis, or an endoscopist who knows what they're looking at when they do a pouchoscopy? Unless you have all of those things, you shouldn't be doing it.
Yeah. Now,
people are very good at conferences at saying, oh, well, of course. But when you actually drill down into their practice, they won't, some people will not stop doing this. And I think it's partly because it's one of the biggest operations that bowel surgeons can do. And therefore you're a macho, full-on colorectal surgeon if you do it. People also do very odd things. You know, I saw somebody the other day who said that her surgeon had said to her, I've never done one of these since I did one with someone when I was a trainee. I haven't done one as a consultant, but I'll give it a go. I mean, I just don't understand why you would do that. So as patients, well, maybe the group, I think I would have very little compunction about actually listing the numbers of looking at the volumes coming out of each center, and I know it feels difficult, but you should actually be able to ask whoever you're seeing at the hospital, what is the pouch volume in this hospital?
So I'm a patient. I go along to my GP. I say my pouch is giving me a lot of jip, a lot of problems. GP says, I don't really know what I'm doing. Would you like to be referred? Yes, please, I'll be referred. And they'll give them a referral to the local hospital.
So the local hospital, so in that slideshow, I said pathways.
Yeah.
The local hospital, every colorectal surgeon should have a pathway. They should know, and they'll be the people who know. But every colorectal surgeon should know where their local pouch center is.
Right.
And they should be referring patients to there.
Yeah. Okay.
So the sorts of words that people should be using are, what is the unit, what is the unit volume of pouches here? Are you a pouch center? Do you have a multidisciplinary pouch team? And if not, where is the local pouch center, the nearest pouch center? And those are the sorts of words that people should be, I mean, maybe the Red Line Group should be writing those sorts of words down and putting them on a website in the public domain and saying, these are the sorts of questions you should be asking. Because if surgeons and other health professionals are not going to offer that information, patients should be able to ask.
Yeah.
And I know it's really difficult to ask, but if you were going to go off and buy something, I mean, I'm trying to think of an example. I can't off the top. I mean, if you've got somebody come and fit your bathroom, you would actually quite like to know how many bathrooms they fitted. If they were a roof guy and they said, oh, I don't usually do bathrooms, but it can't be that difficult. You wouldn't, you would expect to be able to ask those questions. Yeah. And people shouldn't. Yeah. The only way around this is, part of the way around it is if people are asking the right questions.
We may well be knocking on your door for a favour there, in terms of those questions, because also I think it gives people permission. Yeah. It gives them courage to ask the questions if they've been recommended.
And remember, everybody with a pouch has a rare disease.
Yeah.
And there is a rare disease. I can't quite remember the word. There's a rare disease strategy in the NHS. Now, most of that, it's all very tunnel vision. It's about genetically inherited rare diseases.
Yeah.
But there is a rare disease strategy. And actually, having a pouch counts as a rare disease in terms of uncommonness. And therefore, to me, it should have the same level of specialist care as any, just because it's a surgically created rare disease doesn't make it any different from something you've inherited. It's 6,000 people in the country, 1 in 10,000 people. It's rare.
Let me thank you for that. Let me invite Davinder. He's had his hand up, and that'll also give me a chance to look at some of the questions. Davinder.
Hi, hello, thanks for that. I've had a pouch for 3 years, and and it was done in Wolverhampton. I've always had problems fully emptying in the evening. So I got my GP to refer me to St. Mark's Hospital, and I came to see the pouch nurse last week, and she did notice, on the whole, everything's fine, but the rectum was longer than normal, that you do. So how do I find that that's my issue for empty, because the Wolverhampton leaves a longer rectum?
It's not a yeah. There shouldn't be a longer rectum. Doesn't matter where the pouch has been done. So many of these things are not totally straightforward. It's not just one issue. But if you are somebody who tends towards having difficulty emptying the pouch and the rectum is left a little bit long, that's it adds to the problem.
Right.
You know, basically, what are you asking me? Sorry,
because you mentioned that if it's a longer rectum, you might have problems emptying. Well, that's what my issue's been now for 3 years. I find it very hard to empty fully. I do eventually, but it takes a long time. And I'm not on medication, nothing like that. And so I did check it. She said the rectum was longer, the muscles seem all right, everything else seems fine. That's the only thing she noticed that was unusual. But what I do find is if I soak, that helps to relax the muscles. I can fully empty then.
Well, I mean, the important things are, first of all, we try and make sure that rectum's not inflamed, because if it's inflamed, it acts more of a blockage than if it's not inflamed. Sometimes people need to use a Medina catheter or aquaflush to actually put something into the pouch to let it empty. In some patients, if it's really long, like the pictures I showed, we can do an operation to shorten it. But if it's only a little bit too long, that's really difficult and really risky, and often not feasible, actually. A really long rectum is actually quite easy to deal with. The ones that are difficult are the ones that are just a little bit too long. But I mean, you know, it's important that you've had that assessment.
So if I've had the assessment with a pouch nurse, can I be seen by a surgeon to see whether that's okay or not?
Well, it depends who you've been referred to.
The pouch nurses asked me to refer them to them, and they're basically saying, as far as they can see, everything's okay. So well, it's very difficult without, you know, I think it depends on your local care and what the communication is between the nurses and so, I mean, seeing a surgeon is not really very helpful. Everybody wants to see a consultant, everybody wants to see a surgeon, but actually, what's the surgeon going to do? You've got to remember that pouch nurses probably have more experience of pouches than most surgeons. First of all, it's true. Particularly, did you see Zara? Did you say you see Zara? Yes, yeah.
Okay, so Zara probably has more experience of pouches than 90% of colorectal consultants in this country.
Okay.
So because she's wearing a dress and it's called a nurse, does not mean that she doesn't know what she's talking about, and she is probably better than virtually anybody. That's the first thing. The second thing is surgeons do operations. A slightly long rectum is not something we would do an operation for. Actually, as I said, what we would do is help with emptying techniques, perhaps if necessary using an irrigation device, and making sure that it's not inflamed. Now, you do not need a surgeon to do any of those things. So I don't have this sort of feeling that somehow by seeing a surgeon you're seeing somebody better.
Okay. No, sorry. The question I asked was how long the rectum should be. Whether mine's too long. I wonder who.
It should be 1.5. Well, I think it should be 5 to 10 millimeters. I will tolerate 15 millimeters. That's 1.5 centimeters, and anything longer than that is too long.
Okay, that's fine. Thanks for that. Yeah.
Thank you.
Thank you.
Thank you. Just a couple of questions coming through. What's the sort of waiting time to see an expert at the moment? if you're having pouch problems, or indeed if you've got a defunctioning pouch that you want to be functioning again. But is there, I mean, obviously
the answer is I don't know.
Right.
You know, we've got the most hideous weights partly because of COVID, partly because of under-resource. I've gone part-time, which makes it slightly more complicated, but my next available appointments are in about 6 months.
Gosh, right. Wow.
But you may have noticed, so we're trying to discharge quite a lot of pouch patients from regular follow-up. But to make sure that people can get easy access, because one of the problems we've had is that the clinics have been full of people who are completely fine. And, you know, they come for their checkup and it's all very nice, but they don't have a problem until like a month later. And then, of course, they can't get into the clinic because it's completely full of people who are coming for their checkup and are fine.
Yeah.
And it would be far better to have a much more responsive service, which is what we try and do through the pouch nurses. And the pouch nurses are actually very good at spotting if there's somebody who's got a really bad urgent problem. But, you know, it is difficult. You know, Janindra Warisivitani is on a sabbatical at the moment, but he's got a very good locum, Kate Williams, who talks to me a lot. I've gone part-time, but they've got a locum to fill in my other bit of time called Lisa Massey, who is also very good and also talks to me a lot. And I'm trying to help them develop and upskill very quickly. So, you know, we are busy, but and I know that seems like a very long wait, but so I've seen people who've been struggling for years and years and years.
Yeah.
You know, it's not an acute problem. They've been struggling for years and have basically been messed around.
Yeah. I'll come to you in a moment, Susan. I can see you've got your hand up, but just one related question there. Are there enough resources around the country? St Mark's is obviously a special place, but are there enough resources around the country for referral specialists?
Well, you say we're a special place. We do not have any special funding for this.
No.
You know, nobody does. So there is a thing called specialist commissioning. So for most healthcare work, including surgery, money for the GPs refer patients, and the money then follows to the hospital. Which is why when we discharge people, they need to be re-referred, because it triggers more money coming. And if we didn't do that, we'd go bankrupt. Specialist commissioning is a process outside of that, where actually the NHS pays, Department of Health pays directly for a service. So it's not about the GP referring the patient. There is something set up, and things like transplant surgery are funded in that way. And it's felt that it's probably more appropriate to fund things, very specialist things, in that way. And I think that there are moves to fund pouch in that way, but I don't think it's actually happened. Well, it hasn't happened.
Right.
And it's something we need to push for.
Okay. Thank you for that. I'm going to invite Susan to ask a question. She's had her hand up for a while, and then we'll come back to the lots of questions. Susan.
Okay, can you hear me? Can you hear me?
I can, yes.
Okay. I had my pouch created by Peter Hawley in 1996.
Yep.
And I've had almost 20 years of freedom. It worked perfectly, it gave me a life. Since then, it's really gone downhill to where I can't leave home. I've had one physiology test at Old St Mark's a month or two ago, before it moved to the Central Middlesex, and I was due to come there quite soon, but it's been postponed until May. But the referral was made to you direct before they realised that you were going to be part-time. Because of my problems, they wanted me to actually see you. And obviously you're saying it's delayed even if you've got appointments. Is there any way you can be contacted to give advice?
Well, I am still seeing patients.
Okay.
So I don't know whose clinic you're in, but you
I'm
know,
not in
I
the
think,
clinic yet. I'm having tests.
okay, well, in that case, you're not seeing me, because I see patients before I organize tests usually.
Well, I just got an appointment to have a physiology test, and as I say,
Okay, so I'm not, so that won't be me.
well,
I
you're
am
gonna
still
do
working. I am just doing a reduced amount, so I am still there. So I think I think we've got to get away from this idea about individuals. Okay, you know, the real important strength of there was John Nichols. John Nichols went, everybody thought the world had come to an end. Well, then they got me, and that's why everybody thought the world had come to an end. You know, and then we've got Omar and Janindra, who are great. We've got to get the next generation up and running, and they are, okay, and they are receptive, and they are, the two people I mentioned, Lisa and Kate, are really good. They're two young consultants who listen and talk to me about virtually every case. I've started doing some examination under anaesthetic with them, and you know, we now have a pouch MDT multidisciplinary meeting at St Mark's where all of these difficult cases are discussed, and I go to that, as does Omar. So it is not it is not just about the name of the person on it. It's a team, and one of my jobs is to make sure that the team is all upskilled.
I think that my local hospital, the consultant, has some knowledge of your skills, and particularly wanted me to see you.
Yeah, but that's not relevant, I'm afraid.
No,
We have a team approach. This is a team, okay? This is not an individual thing. You know, it's Manchester United, not Djokovic.
I fully understand that. That's what my local consultant.
Well, it's an interesting thing, because that also shows a lack of insight as to how this is a team game. Okay, you know, this is. Yet they should be referring to the pouch unit at St Mark's, not to one individual person. The pouch unit at St Mark's is a team.
Well, I can't tell you what's happened so far.
Yeah, well,
my symptoms are getting worse day by day.
Yeah, well, you need your test. You need to be seen, and you will be. You will be.
It's now, I can't remember when it is, in May.
Yeah.
So I'm waiting for paperwork. It was March. It was in about 2 weeks' time. But obviously, the amount of patients that's being seen, it's been cancelled and rebooked.
Yeah. Well, I'm sorry about that. It's just really difficult.
No, it's the same. You know, we work at the local hospital, yeah. So I know exactly what's happening. So you know, it's not new to me. We're staff at our local hospital, and that's.
I mean, that's a
very difficult situation, because to go out at all, to leave home, I fast for 24 hours.
Yeah, I know, and you're not alone, and that's why, you know, the important thing is you come to St Mark's, you see somebody who's following those algorithms. You know, people seem to think that I'm some kind of, you know, guru of this. I'm not. It's not difficult. It really isn't difficult.
Your name goes before you.
Well, but you know, it shouldn't be difficult. It's about knowing where, you know, it's like the fault finder. You know, if there's something wrong with your boiler, you follow the thing that says check the power's on, check this is on, check that, do this, and then you get. That's what we're doing. It's not rocket science.
I understand.
Let me butt in, Susan. If I can just butt in, I think it's a little bit unfair for Sue to have to answer personal stories, because she doesn't have the medical notes in front of her. She can't answer personal stories, and she's also there's a lot of comments about people not getting appointments through, about delays, which again.
Well, that's general. That's in general all over the NHS. Can I just say, I've had excellent contact.
Let me ask a couple of questions, Susan, because lots of questions from others here. Given those two factors, is there anything that people can do right now to improve their pouch function? Is there anything that we can do to stave off some of the issues that you've seen? and also the effects of old age as we get older to keep our pouch functioning well?
I don't think so. I think just trying to be sensible with diet, making sure that actually you do know where to get help if you need it. It almost might be sensible to find out before it actually is needed, where is your local pouch centre, and stay fit. And just coming back to the thing about cancellations and so on, our problem is that we are all very under-resourced. And I know it sounds very, for you listening, it just sounds like a glib reply.
Oh, I know.
The trouble is, we cannot do anything about it. The people who can do something about it are you. You can write to your local hospital or write to your MP or write to anybody and say, I have got this, I have had this very specialist surgery and I'm not getting the care I need. Because they won't listen to us, they'll listen to you. And that's the real power of groups like the Red Lion Group. And it's really important that we hear these stories, but I can't do anything about it and nobody listens to me in terms of management, because doctors always want more resource, but the people they'll listen to are you. If you know what it is you should be getting and you're not getting it, and I think you do know what you should be getting, and I think you know you're not getting it, you need to flag that up.
Can I repeat what I said before? I've had excellent contact with the stoma nurses. They've given me suggestions. If you email them, they answer you that day, next day, whatever. I've not had an email that I've sent them where they haven't replied, and sometimes they've phoned. They've been excellent in every way, can't fault them. And we do support our local hospital because we're the League of Friends. Well, my husband and I are on the League of Friends, and we buy equipment for the stoma department, whatever they need. So we do support them as much as we can. So it's a shame other people can't do that at their local hospital too.
Indeed, well
Thank
said.
you very much for answering my questions, but well as you did. Thank you.
Indeed, well said. And there's a great point there, and I think there's an opportunity for lobbying by Red Lion Group and by the Kangaroo Club in Oxford and by the IPAA subgroup to get together and lobby together on a national level. I think that's a big opportunity for us in the coming couple of years. Certainly Red Lion Group has been very, very active, and would like to extend our services to our membership and beyond to campaign for better comprehensive services around the UK. I think that's very important. There are fantastic centres of excellence, anyway, enough said. A couple more questions if we may, and I appreciate two more. I appreciate 3:30 in the morning. It's been a long day for you already, and these are great questions. So if we can indulge you for a short period onward. A question from Hitesh about alternatives to JPouches or pouches. Is there any developments, for example, you mentioned an artificial bowel. Are there any developments on the horizon or beyond that you're aware of that might take the place of a pouch in the future?
No.
Okay, that's nice and quick. A question about defunctioning pouches and how long it's appropriate or safe or reasonable to have a defunctioning pouch before you would either recommend that the pouch was reconnected or removed.
So I would only recommend a pouch is reconnected if you've found a problem and sorted it out. I come across patients who seem to have had pouch rest. Somebody's made an ileostomy, they've had trouble, somebody's made an ileostomy, and then the ileostomy gets closed. Well, what's changed? It doesn't make any sense to me. Unless you do something that's changed the situation, it makes no sense. In terms of how long, well, if a pouch is not in use, it does shrivel a bit. It's a bit like putting a leg in plaster. If you don't use the muscles, when the plaster comes off, you fall over because your leg's withered. And that will happen to a pouch if it's not in use. How long? Difficult to know. It's probably fine for a year. 2 years, probably okay. Once you start getting beyond that, actually that pouch may never be quite what it could have been. that sort of ballpark length of time.
Okay, thanks very much indeed. Have you got time for one more quick
I'll do one more and then I really must stop.
Yeah, of course. It's one of our regulars, Peter Flitcroft, has asked a very straightforward question. What's the prevalence of SIBO in JPouches? And for the benefit of people like me, it would be good to know what SIBO stands for.
It's SIBO.
Yeah.
Peter.
So
it's bacterial overgrowth. Small
Yeah.
intestinal bacterial overgrowth.
Yeah.
So I don't know is the answer. In normal pouches, probably quite low. It'll be, so what it is a problem usually when there's what we call stasis, when there's stagnant poo. So usually if there's a blockage, or in a pouch, if the pouch doesn't empty fully, that you get too much bacteria in there. And that causes problems with inflammation. And also produces various chemicals as well, and it responds to antibiotics. So it should be zero if people are emptying their pouches fully and they've got no blockages. But I think this is, I did mention that some people appear to have an inflamed pouch, and it's just because they're not emptying fully. And if you can get them to empty fully, the inflammation goes away. And I think that is a manifestation of bacterial overgrowth. So there's not a simple figure I can give. I think it's probably a factor in some patients who have an emptying problem or a stricture. But what you need to do is treat the emptying problem or stricture. Maybe you need to give one treatment for the bacterial overgrowth as well, but just constantly treating the bacterial overgrowth is pointless. You've got to get rid of the underlying problem. It's like a blocked drain. You know, unblock the drain. Don't just deal with the smell.
Well, we have to draw the session to a close, and what a great way to draw it to a close. I would just like to say apologies if I haven't asked the questions that you tabled. There've been a couple of people who've tabled a few questions, very detailed questions about medical care, where they've been having problems, and I'm sorry I wasn't able to table them. I would say to you, if I haven't asked the questions, do have a look at the Redline Group webinars that have been recorded in the past. There's one about fissures, which might answer one of the questions that's been asked. It's a very good sort of 40-minute lecture on fissures with questions, and that might give you some answers to the questions that you ask. Like I said, I'm sorry that we haven't had time for all the questions, but totally understandable given your long day already. And there are many comments now coming in thanking you for a tremendous presentation. I would just like to completely endorse that. That was absolutely fantastic. Clearly, a presentation born of your immense experience in dealing with pouch people with problems, and we're all, on behalf of everybody who's on the call and all pouches everywhere, we're absolutely delighted that there are people like yourselves who are able to help pouches when they get into problem. And I would also acknowledge the pouch nurses at St. Mark's and elsewhere as well. Absolutely fabulous. Thank you very much indeed on behalf of everybody. Just before everybody goes, I'd just like to remind you of a couple more events coming up on the Redline Group calendar. I'll have to read these because I've forgotten them. The next forum chat for pouches, we do it every month, is on, it's not that page. Oh, well, we'll put it down. It's on the 7th of March. I'm going to rely on my mental capacity. 7th of March, 7 o'clock, I think it is. Anyway, it's on the website. Have a look. 14th of May, we're going to our first face-to-face information day, probably going to be at Central Middlesex Hospital, but we're going to confirm the location. But please put it in your diaries, 14th of May, Saturday, 14th of May. And the other thing to mention is a sponsored walk, 26th of June. It's a big sort of event. It's going to be in London, but there's also the opportunity wherever you are to take part. 13 miles sponsored walk for Redline Group, raise some funds to help us with things like lobbying, which Sue mentioned tonight. So there's something for everyone. Please take a look at the website. Thank you to Sue. Thank you to Gary for pressing all the buttons. And thank you all for your attendance and your attention. Really nice to see everybody. Take
The
care.
recording will be available probably tomorrow.
Thank you, Gary. Yeah. So
Okay.
on the website you can download and have a watch. Thank you, Sue. Thank you, everyone.
Bye.
Okay.